First of all, thank you all for inviting us to participate. The Affordable Care Act, I'd like to approach it from hospital industries and then specifically to Our Lady of the Lake. When you look at, first of all, can I see a show of hands of everyone who's read all thousands of pages of the Affordable Care Act? Okay. I did the Cliff Notes one night, but so kudos to those who have actually plowed through it. From a hospital perspective, it's very interesting. It specifically speaks to the hospital's requirements around financial assistance and making sure that there are written programs and communicated programs around financial assistance and communicating with patients before collecting any type of co-payments or insurance. And speaks to the tax-exempt status and maintaining that hospitals participate in community benefit and participate in a community health needs assessment in order to maintain their tax-exempt status. Then it speaks to the quality of the organizations by speaking about value-based purchasing and accountable care organizations. And so first I'll address from the Lake's perspective the financial assistance and the community health needs assessment. Those policies have been published and in effect for many, many years. As a matter of fact, our financial assistance programs and requirements are less than what the federal government required, meaning that at 100% of the federal poverty level, we go up to 400% of FPL to be able to access our financial assistance programs. So very much in line and supportive of those requirements. About the community health needs assessment, it's very interesting in that Baton Rouge took the perspective that all of the hospitals in this community participated in one community health needs assessment. As you look across the nation, there are about a handful of communities that actually collaborated on a single community health needs assessment. So very proud that Baton Rouge, under the auspices of the Mayor's Healthy Cities Initiative, had Ochsner Medical Center, Our Lady of the Lake, Women's Hospital, back then Earl K. Long was a part of the process, Baton Rouge General, and Lane all participated in a single community health needs assessment that identified 10 priority areas and then went further to use the Institute for Healthcare Improvement to say these are the 4 community-based efforts that we will attack as a community. And those are HIV/AIDS, mental and behavioral health, overutilization of the emergency room, and obesity. So from that perspective, certainly meet the intent of the ACA. And for this year, when the group got together, because it's every 3 years you have to undertake this community health needs assessment, for 2015, we've agreed that we will do that process again as the Mayor's Healthy Cities Initiative. And for the first time this year, we have a single implementation plan. The government doesn't require a single implementation plan. They require individual hospitals to have an implementation plan, but we agreed as a community that we would have one implementation plan, and then we would all speak to our efforts around that. So that's pretty exciting because we've not been able to identify any other community in the nation that has a single implementation plan. So that's an exciting thing for our community. We thought it was exciting.
Yes,
I guess you got to get excited about some of these things.
Yes.
Around the values-based purchasing, this is, you either have to be a statistician or a degree in decision analysis to figure out value-based purchasing. But what it's supposed to mean is that you take processes of care, you take experience of care or satisfaction, and you look at outcomes. And what that value-based purchasing does is it kind of pulls back from your Medicare payments a certain percentage, and each year it gets a little bit greater as it rolls up to 2016. And then based upon your performance as an institution, you get some of that back in a bundle, in a payment. And so for our own experiences, we started testing this in 2012 and pretending like we were under a bundled payment kind of model. And as you look back, if you take 1.25% of our Medicare payments, that's about $1,456,000. That's a lot of Medicare care that's delivered in our institution. And so if you held that back and we looked at what we would get from achieving all of the targets that we had, we left about $188,000 on the table. So that was a wake-up call for us to make sure that we're truly focusing on the processes of care, the outcomes, and the experience, so that we would be able to retain all of those Medicare payments. That's not even talking about incentives, because the way the program works is that some people have to lose in order for others to gain. So it puts you in a pretty competitive environment to make sure that you're focusing on the right things. Those around processes of care have to do with acute MI, congestive heart failure, and pneumonia, and a whole bunch of other things that continuously change as the program moves forward. The new models coming forward will add for this year efficiency. So they'll be looking at throughput questions and adding to that as far as how you get your value-based purchasing payments. Around the accountable care organizations, there are only 2 institutions in our state that are recognized by CMS as having some form of an accountable care organization. Ochsner Health System is considered a shared savings plan under the accountable care through CMS. They don't have any projects going on that I'm aware of just yet, but they are recognized as a shared savings accountable care organization. In Louisiana, there are 2 demonstration projects under the accountable care. Amedisys is a level 3, or which is strictly in the post-acute care, but their project is on hold at this time. And Our Lady of the Lake participates in a level 2, which is acute care and post-acute care bundle payment project around orthopedics, joint replacements. So in the state of Louisiana, there's only one ACO bundled payment project at this point in time, and that is at Our Lady of the Lake. And so what are the benefits of that? It aligns the hospital along with the physicians, because you get paid for an episode of care. In the insurance world, you guys know what that means. You know, the ETG, you get paid one payment for everything that occurs as a part of that episode of care. And so this aligns the hospital and the physicians to make sure that we're doing the right thing at the right time for the right reason, and very importantly, with the right resource. And so it's been a good demonstration project. We've learned a lot of things. We've learned a lot about physician participation and engagement and understanding from each other and with each other about products and risk screenings and stratifying patients and making sure that we have people in the right categories. So it's been a wonderful demonstration project, and we look forward to learning more from that as it goes along. So to kind of sum all that up from a hospital perspective, that's where the Affordable Care Act talks about cost and quality and the impact on the hospital systems.
Thank you. Jonathan?
Again, thank you, and thank you for allowing us to be here and to share a little bit today. Regarding the community health centers, it's kind of twofold. There's an operational aspect and then certainly the patient aspect. Operationally speaking, there was quite a bit of attention and responsibility thrust toward the community health centers. There was a certain expectation from our federal partner, the government, to instigate and train a number of community certified application counselors. And they were to go and do a great deal of in-reach and outreach and educate not only the patients but the community about certain aspects of the Affordable Care Act, but also about specific terms around the marketplace. So health literacy became a focal point of the community health centers. Not only the providers trying to share some of that information and instruction, but again, trying to reach out through, there were several new partnerships. We started advertising on the radio. We started working with Together Baton Rouge. We worked with the Navigators. We worked with various church organizations and so on. So anyone that would allow us to get in front of our patients outside of our health centers became a partner going forward. We learned a great deal more about our patients and some of the circumstances that they live in. Most of these patients did not have an earlier access or experience with most health insurance, even, what's the difference between deductible and copay. I might go back and just say, for those of you that are not familiar, there are 30 federally qualified health center organizations in the state. We operate approximately 140 sites around the state, both urban and rural. 40% of those patients are Medicaid eligible. Another 40% are uninsured. So quite frankly, out of the 300,000 that we treat, well over 100,000 have never entered the insurance market and are considered self-pay. And so typically when those people come in, they are offered our services on a sliding fee based on their income. So that is their insurance, the way they look at it, coming into us, providing proof of income, and then having some sort of discounted price. So explaining an insurance market, explaining who might be eligible and who not. Of those uninsured, approximately 75% of them fall below 100% of poverty. So we became experts on income levels, marketplace eligibility criteria, and then tried to convey that to the patients and follow up. Because, without going too much into it, Medicaid expansion was initially part of the Affordable Care Act and expected, we had to go and explain to a lot of people what was eligibility based on income and when it would apply and when it would not, and then try to find those services for those that were ineligible for the marketplace. So as operationally speaking, for lack of a better term, I know some of our health center directors are here today, in a lot of ways it was business as usual. We were still trying to follow up with this certain patient population, explain to them their responsibility, and explain to them the facets of the insurance. Now, operationally speaking, again, trying to take on new staff and new services, and then, continuing, when we talk about access to care, there's always been an effort in trying to reach our population and provide them additional access to additional services, especially around specialists. So with the disruption of all of our referral systems throughout this process, we've got a lot of issues trying to renegotiate contracts. And again, when the marketplace opened up, that opened up a lot more contracting opportunities and responsibilities with different plans. So the health centers had their own learning curve in addition to trying to educate the patients through, this continuing transition. And we tried to preach internally that this was, and I'm sure you've heard it, this is going to be a marathon, not a sprint. We weren't going to learn it all. We weren't all going to fix every issue that came up in this first year. I know that CMS and both HHS continue. I've received a couple of flyers. The ACA regional meeting is going to occur in June 2nd. So what did we learn from it going forward? So I really don't think that anyone expected us to just coast through this or streamline the process in this initial year. But certainly, again, the responsibility turns into an opportunity on the longer term.
I didn't think so. Okay, I'll do my best. Which actually brings up an important point about me. I am not an insurance expert, not a public speaker. I'm a laparoscopist, so to see me do what I do best, we would need to be in the operating room with the lights off, doing surgery on a patient, and let me know if you'd like to come see me do that sometime. But I'm very excited about the opportunity to talk to you today about what this is like from a provider's point of view. My job is completely different from the job of most of the people in this room. Whether I'm in the office or in the operating room, I am doing the best possible job that I can do for one person. And I know that I'm looking at a room full of people who are tasked with providing the best possible health care to thousands, and also calculating how to pay for it. And so I express that sympathy to you when I tell you that my point of view is really from the doctor's lounge, from the exam room, from the operating room, and I do not know how you pay for it. So a couple of things come to mind. When you talk to doctors about their experience working with patients that have this new insurance coverage, I think that you all might be surprised how many physicians will say that they haven't seen a patient yet. I won't belabor the very, very well-documented delays, postponements, changes, amendments. All of this on the ground has the consequence that a lot of doctors are seeing their first couple of patients with this coverage or have yet to see a patient. And thus, we may be able to discuss this and have a better analysis at this convention next year than today. Secondly, when I speak to doctors about their experience with these products, those of them that have seen them suggest that it's like just another insurance, and so they're going through pre-authorization and billing and things like that. And what they're telling me is that it's really quite ordinary, and I consider that to be a good thing. Just another insurance, quote unquote, and I think that's what they were supposed to be. On another note, and you heard from my bio, there is a disease that I have a particular interest in that the Affordable Care Act plans have a negative impact on, and that is access to care for the treatment of obesity. Blue Cross Blue Shield of Louisiana was used as a benchmark as our plans were designed, and as a result, there is no coverage for nutrition, exercise, weight loss medications, or bariatric surgery for the treatment of obesity in Louisiana. 37 states in the country have at least one Affordable Care Act plan that provides bariatric surgery. So I'm not suggesting that Louisiana consider anything that's particularly radical. Why those states are doing that are because of the weight-related medical problems that we can put into remission or ease with treatment. I can put type 2 diabetes into remission within hours of surgery. I can improve high cholesterol and delay or eliminate the heart attack, strokes, and death that go along with that. I can take weight off of weight-bearing joints and prevent or delay joint replacements. I can decrease the risk of some of the most common cancers. And so I would argue that this is something that your industry should look at again. And I do believe that it will save you money, but what I care about more is that it will ease the suffering of loss of patients. And so that's something that I think should be revisited. To end on something more positive, the patients that I have seen with these shiny new insurance cards have been in my clinic downtown. And to paint a picture for you, my LSU clinic is located in what used to be Lord and Taylor, across the street from the Superdome. The people are excellent. The facility is exactly as poor as you might imagine a retrofitted shopping mall would be nearly 9 years after Katrina. And so I think that it's impressive that my patients who now have insurance and could take that insurance to another facility are returning to Lord and Taylor. And I'm hoping that loyalty to a doctor and to a hospital may translate into better reimbursement for some of our facilities that have been bearing the burden of free care, as these free care patients are transitioning now to insured patients. And so that's something that I think may be a positive result. I hope that my microscopic perspective on your big problems is useful to you in some way, and I appreciate the opportunity to express my point of view.
Thank you. Dr. Moore, I have a question. From the Louisiana Medical Society's perception, how do they, or do you know if they actually are concerned about the primary care provider issue in Louisiana, the shortages? Can you address that a little bit?
It's a big question, and there are lots of incentives going on many levels, all the way down to trying to support the students who are headed that direction. And I think that is the most long-term thing that's going to make a difference. There's some financial and and just extra support for people that are planning to practice in that way. I think at the student level is going to be the biggest way to solve the problem in the long term.
Thank you.
Sure.
Yeah, I was going to make a comment. There was a bill that was being looked at this session. It's been talked about collaborative practices where nurse practitioners have to have a collaborating physician that they work with. And in most states, they're expanding that authority so that a physician can have multiple nurse practitioners, especially in long-term acute care settings, where there's consistency of patient access and such. And yet there was a movement in our state to limit that, to have a physician only oversee 2 collaborative nurse practices. Well, I'm glad to say that that's not moving forward, that, that we're still going to, it is a physician and nurse practitioner collaborating agreement with no restrictions on those numbers. It's really up to the physician themselves as to what they can oversee. And so I think that's an important aspect to know, that in most places where we're trying to open up access, it's really important that we not put policy in place that then limits access. That's just from the provider's perspective of having long-term care programs.
I think that's a good point, and this nurse practitioners can be physician extenders. It speaks to her question about, more primary care in our state.
Absolutely.
Thank you. Let me see a raise of hands. How many folks in here know about federally qualified health centers? That's what I thought. I didn't know much about them either. Jonathan, can you address that just a tiny bit? Because how does federally qualified health centers integrate into this whole process with the providers, with the hospitals, with the insurance industry for us?
Sure. So as it states, it is a federally qualified to where a provider or a community can actually generate an effort and apply to the federal government to become a federally qualified health center. In Louisiana, we've had several grassroots organizations, we've had physician groups, we've had rural health clinics kind of see that process as the best way in their community to address those needs. So upon receiving that designation, there are certain requirements that are made upon the health center. You have to provide a certain level of services, both in primary care, dental, and behavioral health, either under your roof or through a referral basis. And so when we talk about a community health home or a patient-centered medical home, it really does take that integration into effect. And so we've been living that integration for several years. But along with that is the expectation and responsibility of turning no one away based on their inability to pay. So while the services are not free, services are never refused anyone. And so when we talk about a community health center and what it means to the community, not only is sometimes it is the safety net in some of our more rural communities, we certainly also have to provide a continuum of care, whether that be the hospital system, whether it be home health, whether it be other social services. So we try to play that hub around that person's well-being in general, as well as being an economic driver in some of these smaller communities.
Does that help? No. Okay. Well, you'll have to look into it because they got a great website and it explains the whole thing. Khalid, let me ask you a question. There's a lot of concern about emergency room departments and the Affordable Care Act, and previously all these uninsured folks were going to now have insurance. Can you address that a little bit from the Lady of Lake perspective?
Sure. As an industry, if you look to the experience in Massachusetts, when there was global access to care, there was an increase in utilization of emergency room visits. And so in forward thinking, people were concerned that might be. I don't know that we've seen that. I know that we have seen emergency room visits increase across Louisiana, and we've seen them increase in Baton Rouge. How much of that, if you remember, April 15th of last year is when Earl K. Long closed. And so there was this belief that our emergency rooms across the community would be inundated with people who previously had sought care at Earl K. Long. When you looked at the data and the analytics of the patients that sought care at Earl K. Long, 70 to 80% of those patients were clinic level visits. That meant only 20 to 30% of 30,000 visits were really emergency level care. And so the urgent care center was opened up on Airline Highway 24 hours a day, 7 days a week in order to provide urgent care. And they're seeing about 36,000 patients a year. So one would say, everything that was at OK Long just moved 1 mile up the street. Well, you can't make that assessment or that assumption, but that program does see more than 36,000 patients a year now. In emergency rooms, what we've been very, very cognizant about is looking at time to treatment. And in some communities, you'll see billboards about wait times for the ER. You know, come here because you only wait 10 minutes or, 11 minutes or something. You have to be very careful to look at what the data about a wait time is, because I'll just speak to our institution. We don't track wait time in the ER because we have a physician that sits in the registration area. So when a patient walks up to be registered, there's a physician that is eyeballing that patient right then and there, doing that quick assessment of, yes, they're short of breath, their coloring looks bad, they look really sick, you need to go ahead and bring them back to triage. Or someone who comes in as, I've had a headache and this and that and the other, and they're doing that real quick triaging on admit. So within 1 to 2 minutes of walking into an emergency room, into our emergency room, you're already getting that medical assessment. So, we don't post a ER wait time. What we post is an ER throughput time. And we have a goal to get our ER throughput down to 180 minutes from the time you walk in through registration, treatment, and disposition, which means discharge or going to your room, would be a 3-hour process. Now, for level 1 and 2 patients, it's less than 60 minutes. A level 1 and 2 patients are your trauma patients, your very sick patients, patients that, for the most part, are brought in by ambulance. Rarely do you have someone that sick being brought in by a car, but it does happen. Those patients, less than 60 minutes. We're not down to the 180 for the 4, 5s, and 6s. We're at 211 minutes. So we're getting close, and it's now that really hard work to get those last few minutes off. And so that's our experience around the emergency room. As a community, the best thing that we can do are educate people to seek care at the right place at the right time. You have a whole network of primary care clinics for people to be seen for chronic diseases. You have urgent care centers. You have, here in Baton Rouge, Lake After Hours, you have, they used to call them Doc in a Box. They're all part of a continuum. When you teach patients to seek care at the appropriate level, you don't have stacking in the emergency rooms that can occur. That's all part of understanding where to go for care in the right amount of time. And that's what a good community-based effort around overutilization of EDs speaks to. How do you teach people where to go for the right care at the right
That's hard.
1 minute.
1 minute, wow. I don't do anything in 1 minute.
It's a test.
It's a test. We're all in this together. It's really hard as we prepare for this to separate hospital from physician, from community providers. It's going to take all of us collectively working together on issues. What I would encourage you to do is it's here. Let's just keep figuring out how we make it work.
Thank you.
And along with that, it's and I've talked to other provider groups, it's no longer us versus them, and it's just us. Mm-hmm. And so recognizing what the issues like the mental health needs to be part of that primary care solution, especially in long-term chronic conditions. Again, just trying to determine each provider's role and understanding that no role can go vacant.
Yep.
I agree with both of you. I think what all of us are here doing today is necessary and important. We need to keep working together and try and provide the best care we can for everybody. We know that it's not perfect, but if we keep working and keep talking, that's how we're going to find our way through.